بسم الله الرحمن الرحيم. نبتدي ان شاء الله اول توك في السيشن. الدكتور احمد زغلول هيتكلم على الاوبتيك نيوروباثي وات تو دو. اتفضل.
Good morning, everyone. Thank you for having me for the third successive year and many more years to come, inshallah. Our session today is about optic neuropathy. We all know that in order to see well, we must have a functioning optic nerve. The optic nerve, when we step back to basics, the optic nerve consists of millions of axons of ganglion cells and a critical bundle of nerve fiber layer that transmits the visual signal from the eye to the brain. So any disruption of this pathway may impair our vision, either temporary or permanently, mildly, moderate, severe. And we can talk about optic neuropathy from many aspects. We can talk from the etiology of optic neuropathy, from the onset, from the course, from the duration, from the subtypes of optic neuropathy. And when we come to the optic neuropathy symptoms, it differs from person to person, and it differs according to the subtype of optic neuropathy. Mainly, it causes vision problems like blurred vision up to loss of vision, complete loss of vision, no PL. It can cause loss of color vision. The patient can come and say that he sees the colors washed out, especially the red color, the red and green, but mainly red color. It can cause, as we said, complete loss of vision. It can cause pain, especially with eye movement in inflammatory cases. And it can cause just discomfort, photopsia. And so we can go to the etiology and subtypes of optic neuropathy. It tells us much more about the symptoms that the patient will come with. Types and subtypes of optic neuropathy, we can categorize them into inflammatory causes. Mainly, for sure, we think the first thing about MS, but it is not the only case, but it is the most common case, MS. Also, infective optic neuropathy should be considered as it will change the plan of treatment completely. Ischemic cases or ischemic causes of optic neuropathy, we know the optic nerve, we can divide the optic nerve into prelaminar, laminar, postlaminar, each of which has its own blood supply. Reduced blood flow in any part or any portion of the optic nerve can cause ischemic optic neuropathy. We subdivide ischemic optic neuropathy, as Dr. Heidi said in details, thank you, into anterior ischemic optic neuropathy or posterior ischemic optic neuropathy. Most commonly anterior ischemic optic neuropathy, and we should deal with anterior ischemic optic neuropathy as emergency, as Dr. Heidi said. Anterior ischemic optic neuropathy comes when the posterior ciliary artery, which supplies the laminar portion of the optic nerve, gets affected. We should differ between arthritic or non-arthritic anterior ischemic optic neuropathy, as arthritic anterior ischemic optic neuropathy diagnosis can be life-saving, not just sight-saving. We differentiate between anterior ischemic optic neuropathy and non-arthritic anterior ischemic optic neuropathy by some investigations or laboratory tests like ESR, C-reactive protein, platelet count, and if we suspected, and for sure a temporal artery biopsy, but it is more invasive, and if we suspected arthritic anterior ischemic optic neuropathy, the patient should be referred as soon as possible. Even we can start treatment by pulse steroids before referral of the patient or before waiting for the result if we suspect arthritic anterior ischemic optic neuropathy, as we can avoid dissecting aortic aneurysm or any major artery embolism. Posterior ischemic optic neuropathy, it is less common than anterior ischemic optic neuropathy, but it happens when the pial plexus that supply the posterior portion of the optic nerve get affected. Also, it can be caused by arthritic or non-arthritic posterior ischemic optic neuropathy. Hereditary genetics like liver hereditary optic neuropathy. Toxic is very important, and it requires detailed history from the patient, and it requires the doctor to be detail oriented and good observation of the patient to suspect, because many patients deny that they had methanol. We have seen a lot of cases in our hospital, by the way, and the patient were very unexpected that they took methanol or certain drugs. And this is the pictures of optic neuropathy, and the other one is the secondary optic atrophy. If the diagnosis is not reached early or the treatment plan was insufficient. Nutritional, like deficiency of vitamin B12. To find the cause of the optic neuropathy, sometimes it is very challenging, and it requires many departments to collaborate together to find out the diagnosis of optic neuropathy. It will affect the treatment plan, it will affect the prognosis. Trauma, physical injury to the optic nerve, and we can diagnose trauma or optic neuropathy after trauma mainly by CT or MRI. Compressive pressure from tumors or other structures, or even increased intracranial tension, which has become very common. Each clinic we have 2 or 3 cases with benign increased intracranial tension. I don't know, it is related mainly to oral contraceptive pills or other drugs, lack of exercise of many patients. It happens to middle-aged females, and now we see it in young children. This has become very common. Diagnosis and clinical approach. As we said, that optic neuropathy has onset and course and duration. Rapid onset of symptoms happens in demyelinating. Demyelinating, we said, like MS, it is not the only differential diagnosis of demyelinating lesions. It can also happen in neuromyelitis optica, when bilateral optic neuritis happens, or Adams syndrome, acute demyelinating encephalomalacia. It can happen in many inflammatory diseases, and the diagnosis of demyelination is challenging not only for ophthalmologists but also for neurologists, as he should do MRI and sometimes CSF analysis, and should have difference in sight and duration, and it takes long time to establish the diagnosis of demyelinating lesions, mainly MS or multiple sclerosis. Inflammatory conditions, other inflammatory conditions like sarcoidosis, like lupus, can also cause optic neuropathy with rapid onset. Ischemic causes optic neuropathy with rapid onset. Traumatic, abrupt onset. Gradual course suggests that there is a compressive lesion, there is a toxic lesion, nutritional, hereditary etiologies, and there is another missing one. I didn't try it, but we shouldn't forget the gradual course of optic neuropathy. The most common one is glaucoma. Glaucoma is an optic neuropathy with or without raised intraocular tension. We should put in mind that the most common, it is responsible for 3.5% of optic neuropathies worldwide. We do visual field testing, we do neuroimaging like MRI, you can see the white plaques. But by the way, don't establish the diagnosis. And if we have neurologists here can tell us more. OCT, we see the retinal nerve fiber layers. OCT is most important in following up the optic neuritis or optic neuropathy and the progression of the disease. Either it is progressing, regressing, chronic. We can see the progression and follow up the treatment by OCT, but it is not conclusive. Treatment and prognosis, treatment strategies are cause specific. Most cases of optic neuropathy or optic neuritis are treated with pulse steroid into 1 gram methylprednisolone, 3 to 5 days. We as ophthalmologists used to give it 3 days, but neurologists extend to 5 days. Most of the studies have demonstrated that giving a pulse steroid therapy doesn't affect the final outcome. But it speeds up recovery, just speeding up recovery. And in some cases like ischemic optic neuropathy, management focuses on addressing the underlying vascular risk factors. And we will come to this in refer. Toxic and nutritional involves removing the offending agent and correcting deficiencies respectively to prevent further damage. We come back to the topic of the lecture, when to refer a case of optic neuropathy or what to do. Most of us, when we find a case of optic neuropathy, there is a point that we don't know what to do next. Shall I start treatment? Shall I investigate? Shall I just refer? The most important case is when you refer the patient immediately when he has acute vision loss, sudden or rapidly progressive vision loss, especially if associated with pain, double vision, or other neurological symptoms. Suspected optic neuritis, symptoms like unilateral vision loss, pain with eye movement or color vision, particularly in younger patients, may suggest multiple sclerosis. Unexplained optic atrophy, progressive or unexplained optic disc pallor on exam, suggesting chronic or prior optic neuropathy. Systemic symptoms, accompanying symptoms like headache, jaw claudication. As Dr. Heidi said, this is a characteristic for arthritic anterior ischemic optic neuropathy or weight loss. Atypical features like bilateral involvement, as we know in MS or multiple sclerosis, most of the cases come with unilateral affection, and many patients, around 25 patients, come to the ophthalmologist first before going to other neurological symptoms. Lack of recovery in suspected optic neuritis or findings not consistent with common causes. Compressive lesions, imaging is much more important here. Toxic nutritional causes, we refer these patients to a gastroenterologist. Pediatric cases, any optic neuropathy in children as causes, congenital, metabolic, or neoplastic, often required urgent evaluation. Associated neurological signs, symptoms like weakness, numbness, or ataxia, suggesting a broader neurological condition. Uncertain diagnosis, cases where the cause is unclear after initial evaluation or response to treatment is poor. Urgent refer, same day or within 24 to 48 hours for acute cases, suspected giant cell arthritis, optic neuritis, or compressive lesions. Okay, we come back. What to do when I have a case? It differs between doctors. Some doctors prefer to do MRI or to do other laboratory tests. Others prefer to immediately refer the patient. Some doctors, some ophthalmologists, I mean by doctors ophthalmologists, some ophthalmologists start treatment with the patient. This is controversial. It is not known whether it is our rule or not. After all, we need collaboration between us and between the neurologist or gastroenterologist, because when you refer the patient, he will refer him back to you in order to follow up the treatment plan or something like that. Thank you very much, and I hope it was interesting. I like optic nerve very much, and thanks to Dr. Ayman Salah. He's not here, unfortunately, but he is my always role model. Thanks to my godfather, Dr. Islam Wali, and thanks to our head of department, Dr. Amgad Od. And thanks for Dr. Muhammad Ibrahim, who helped me in this professional PowerPoint.
شكرا يا
Thank you.
لا بعد زي ما انت عايز. في اي كومنتس على البرزنتيشن الجميل ده؟
هو بس محاضرة جميلة جدا الحقيقة، يعني الواحد سعد بالتقسيمة اللي هو حطها. بس أنا حابب أبدأ عند نقطة رقم 10 اللي هي الانسيرتين دايجنوزس أو الانكلير دايجنوزس. الحقيقة احنا في حالات كتير قوي بنشوفها في يعني يونيلاترال اوبتيك نيوروباثي او نيورايتس اراوند ذا سكند ديكيد اوف لايف، وانت مش عارف توصل للدايجنوزس، وعملت كل الانفستيجيشنز اللي عملتها وحطيتها في الكاتيجوري رقم 10. الحقيقه انا اتوقع في الفتره اللي جايه هيظهر حاجه يعني بنسميها اوتو اميون ميدييتد اوبتيك نيوروباثي، ودي حالات كتير جدا بدانا نشوفها كتير قوي. ناس بيبقوا كويسين خالص وتفاجئ انه عنده اوتو اميون ديزيز. احيانا بتبقى اسوشيتد بحاجات زي بالذات التوكسيك ثايرودايتس، الاوتو اميون ميدييتد توكسيك ثايرودايتس او الهاشيموتوس ديزيز والاوتو اميون ازور ده. ساعات بتيجي ايزوليتد بس، يعني ما تلاقيش عنده اي سيستميك مانيفستيشنز تقول ان عنده اوتو اميون ديزيز. ولما تبعتوا للناس بتاع الاوميونولوجي ويدوروا قالوا في النهايه ان في كاتيجوري اسمه ايزوليتد اوبتيك نيوروباثي، وبيجي نتيجه اوتو اميون ديزيز وبداوا يدوا له الستيرويدز، وبعد كده ممكن يوصل كمان ياخد بيولوجي والتريتمنت المختلفه. فدي نقطه يعني شود بي كونسيدر. النقطه الثانيه ان بدانا نشوف حالات كتير بعد الفيرال انفكشن او بعد الفاكسين بوست فاكسينيتد، وخصوصا مع الكورونا والفاكسين بتاع الكورونا، فشود بي كونسيدرد في الدايجنوز لما تيجي تفكر فيها يعني.
دكتور امجد قطب في محاضره عن نوينج سكوينت، طبعا هو خبير سكوينت.
العفو.
لا ازاي، وكدايجنوزز وكسيرجن كمان. اتفضل دكتور امجد.
ربنا يخليك. صباح الخير. هيتنوا السكوينت حاجه ميستيريس للي مش فاهمه، انما هو في الاخر هي القصه سهله. عشان نفهم سكوينت لازم نفهم شويه ماسلز، لو فهمناه كويس هتلاقي الدنيا بعد كده بقت سهله. احنا عندنا 7 ماسلز اللي بتحكم في القصه. الليفيتور بالبيبري سوبريورس، مع الاعتذار للدكتوره لبنى لان دي بتاعتها هي مش بتاعتي. بعد كده عندنا 6 مين ماسلز: superior rectus، الانفيريور rectus، الميديال rectus، اللاتر rectus، الانفيريور اوبليك، واخيرا السوبيريور اوبليك. بصوا كده على السوبيريور اوبليك. الناس اندر استيميتنج السوبيريور اوبليك مع ان هي ماسل فيري سترونج فيري باورفول، والوحيده اللي الاكشن بتاعها اندايركت، يعني معديه على تروكليا على خطاف كده، وبعد كده منتشره. الانسيرشن بتاعها عامل فاننج تحت السوبيريور. هو ليه مش جايب نفسه؟ طيب ندخل تفصيل شويه اكتر على بالتفصيل ندخل شويه اكتر على الماسلز. احنا عندنا 4 مين cardinal directions: superior، inferior، out، وin، وبرايمري، واب and in، up and out، down and in، down and out. الماسل الاولانيه بتاعتنا superior rectus اللي هي جايه من السوبيريور بارت بتاع الكومن تندينيس رينج وماشيه دايركتلي، والانسيرشن بتاعها انتيريور. لو خدتوا بالكم هتلاقي الماسل مش جايه دايركت، الماسل جايه مايله 23 ديجريز، يعني الاكشن بتاعها هيبقى فيه ميل، وبالتالي هتعمل لي اليفيشن ده المين اكشن بتاعها. وبرضه عشان هي جايه مايله هتعمل لي ادكشن، هتسحب العين لجوه وهتعمل انتورشن. لوجيك صح؟ طيب النيرف سبلاي بتاعها هو الاوكلوموتور اللي هو الثيرد. العضله العضله الثانيه هتبقى الانفيور ريكتس، نفس القصه، جايه من اللور بارت بتاع الكوموتندينيس رينج وماشيه ستريت فورورد، بعد كده داخله على الجلوب تحت الانفيرو اوبليك، برضه نفس الاكشن بتاعها جاي مايل 23 ديجريز، يعني مش ستريت، وبالتالي هتعمل لي ادكشن وهتعمل لي لاتر روتيشن. تخيل انت بتشد المصل كده، هيبقى الاكشن بتاعها لتحت وهتاخد العين معاها لجوه وهتعمل لي اكستورشن. النيرف سبلاي بتاعها هو برضه الثيرد الاوكيلوموتور نيرف. الميديال ريكتس عضله صريحه جايه من الميديال بارت بتاع الكوموتندينيس رينج وماشيه ستريت فورورد، الانسيرشن بتاعها صريح بتاع هنا، فمش هتعمل اي اكشن غير الادكشن. نيرف سبلاي اوكيلوموتور هو الثيرد. اللاترال ريكتس برضه نفس زي الميديال ريكتس، عضله صريحه ما فيهاش اي روتيشن من اللاترال بارت بتاع الكوموتندينيس رينج وبعدين ماشيه للسكليرا من قدام. هتعمل ايه؟ ابدكشن بس، مش هتعمل اي حاجه تاني معاها. طيب عشان ما نتلخبطش، هي اللي فاتوا كلهم كانوا الاوكيلوموتور الثيرد، دي بتعمل ابدكشن يبقى ابديوسنس، ابد وابد، ده السكس نيرف. فاضل لنا الاثنين الاوبليك ماسلز. هو شغال عندك؟ تمام. الاوبليك الاولانيه هي السوبيريور اوبليك وبعد كده الانفيريور اوبليك. السوبيريور اوبليك زي ما احنا شايفينها العضله الوحيده اللي متعلقه على التروكليا والاكشن بتاعها اندايركت. لو دخلنا بتفصيل اكتر تلاقي السوبيريور اوبليك جايه كده متعلقه على التروكليا وبعدين داخله هنا. النيرف سبلاي بتاعها الفورس نيرف. يبقى احنا كان عندنا 3 اوكيلوموتور وواحده فورس وواحده 6. الاكشن بتاعها زي ما احنا قلنا تعمل ديبريشن، ابدكشن وميديال روتيشن. الانفيريور اوبليك من المارجنال اوربيتال مارجن وداخله الانسيرشن بتاعها تحت اللاتر ريكتس عند الماكيولا بالظبط. هتعمل elevation لوجيك، هتعمل extortion وهتعمل abduction. الحركة بتاعت المصل in general بتبقى homogeneous، كل عضلة ليها الاجونست والانتاجونست بتاعها، وسبحان الله الحركة بتبقى symmetrical كده. لغاية كده ما عندناش أي نوع من أنواع الديفيشن، حتى الروتيشن بيبقى فيها الاجونست والانتاجونست. دي هنبقى نشرحها في مرة بعد كده، اللي هي لما هنا مثلا left superior rectus تعمل الاكشن بتاعها، الرايت انفيرو اوبليك هتعمل نفس الاكشن هتساعدها، دي اسمها اليوك ماسل. الليفت انفيرو اوبليك هتشتغل معاها الرايت سوبيريور ريكتس وهكذا. تايبس اوف سكوينت عندنا ده الاورثو، ايزو، اكزو، هايبر، هايبو. ايزوتروبيا اللي هو الانورد ديفيشن واضحه. احنا على فكره بنقيس الانجل دايما بالريفلكس، مش بنبص على منظر العين. بالريفلكس يعني الريفلكس ده طالع لبره يبقى دي انورد ديفيشن. اكزوتروبيا اوتورد ديفيشن برضه بنبص على الريفلكس، الريفلكس داخل لجوه يبقى العضله دي طالعه لبره. هايبرتروبيا classifying السترابيزمز. طبعا right left او alternating. congenital كل ما هو قبل 6 months ده بنسميه congenital، اذا كان ايزو او اكزو او whatever. permanent و intermittent. concomitant اللي هو non paralytic والincomitant. الفرق بينهم ايه؟ الكونكوميتنت هو الانجل از ستيبل في كل الدايركشنز، يعني العيان ده مثلا عنده اكس تي، هتلاقي الاكس تي كذا بريزم، بص يمين بص شمال هي الاكس تي موجوده. الانكوميتنت هتبان بس في دايركشن واحد من الاكشن، يعني دي اورسو في البرايمري ولكن عندها رايت ليفت 6 نيرف، فهي عملت ادكشن هنا 6 نيرف، اللاتر ريكتس ما اشتغلتش فده باراليتيك. المانيفست والليتنت. المانيفست هو اللي ظاهر وثابت، الليتنت مش هيظهر الا بالكفر ان كفر، يعني ده مانيفست، ده ثابت والانجل واضحه. ده نموذج للانترميتنت اللي هو مش هيبان الا بالكفر ان كفر، يعني احنا في البرايمري العين اورثو كل الدايركشنز، عايزين نعمل اجهاد للعين بالكفر ان كفر، مجرد ان انا تكفر العين بيحصل الليتنسي، ولو اي كفرت الاذر اي يحصل برضه نفس القصه الليتنسي، يعني مش هيبان الا بالاكزوشن اللي هو بالكفر ان كفر. الديفيشن بقى بره جوه اب داون whatever. طب ايه المشكله؟ as long as ان الماسلز شغاله كلها مع بعضها في نفس السيمتري، فالعين واخده صوره من اليمين زي العين الشمال. مشكله الحول في الاطفال مينلي مش كوزماتيك بس، كل عين فيكسينج على نفس الاوبجكت، وبالتالي تبعت للبرين صورة واحدة بتعمل لها ستيريوبسس، والبيشنت بيشوفها in 3D. لو احنا عندنا سكوينت هيبقى في عين ميس الايند، العين الميس الايند هتديني صورة بلورد عن الصورة الثانية، وبالتالي المخ كديفنسيف ميكانيزم هيلغي الصورة البلورد، وبالتالي يلغي العين اللي بتدي الصورة البلورد، فهندخل في امبلايوبيا. هنقدر تريكفر ولا لا؟ it depends على الديوريشن وكمية السكوينت. المانجمنت بتاع الاسترابيزمز، العلاجات عندنا ما بتخرجش عن corrective glasses او بريزم، باتشنج، بوتوكس، التريتمنت اوف underlying cause، والاهم طبعا السيرجري. ده عيان اكوماتيف اي تي، مجرد ان انت اديته فول كوركشن بالجلاسز السكوينت اختفى. دي هيلاري كلينتون كانت جات لي العياده، كان عندها ديوريشن، حطينا لها الفرينال بريزم صلحنا بيه شويه السكوينت اللي موجودين. او اورثوبتيك تريتمنت اللي هو بص العصفوره، حط العصفوره في القفص، وده كلام I don't believe in. طبعا التريتمنت اوف اندرلاين كوز اللي هو ايزر كان ستروك او ثايرويد اوفتالمولوجي، ده بنستنى ونتريت الاندرلاين كوز وبعد كده بنختفي السكوينت. لو هندخل في سيرجري، هي كل الفكره ان انا عندي عضله عايز اقلل السترانز بتاعها، ازود الباور بتاعها قصدي، فهعمل كده. نرجع تاني، عندي عضله فيري سترونج عايز اقلل السترينث بتاعها فبعمل لها ريسيشن، او عندي عضله ويك اخد منها حته اللي هو ريسكشن عشان استرنسن المصل. 90% من السيرجريز ما بتخرجش عن البروسيجر دي. ده سيميوليتر بيوريني. بص احنا بنقيس بالريفلكس، تمام. هنفترض ان العيان ده عنده فوريا. في حاجه مش شغاله. الفوريا احنا اتفقنا ان هي مش هتبان الا بالكفر اند كفر، يعني العيان هيبان لك ان هو اورثو مجرد ان انت تعمل اكزertion للعين. العين الويك هي اللي هتديفيت وهيبقى فيكسينج بالاذر اي. لو انا عملت كده هيرجع يتعدل تاني. لو انا غطيت العين دي هترجع تديفيت. طب انا عايز اقيس الانجل بتاعت الديفيشن، هقيسها ازاي؟ بالبريزم. طيب البريزم هوجهه ازاي؟ البريزم اعتبر ان هو له بيز وايبكس، يعني مثلث. السهم بيشاور على الديفيشن، يعني انا هنا لو حطيت له كده انا كده بحطها العكس. سيبك من الفوريا دي، خلينا في التروبيا. العيان ده لبره، يبقى انا احط البريزم ازاي؟ كده ولا اقلبه؟ طيب لو حطيته كده هيحصل ايه؟ الانجل هتزيد. هنقلب البريزم ونشاور على الدايركشن بتاع السكوينت، هو ديفييتنج لبره اكزوتروبيا، يبقى البريزم يشاور ناحيه الديفيشن. طيب اعمل له كفر اند كفر، لسه في موفمنت، يبقى ده البريزم ده مش كافي. طب هزود البريزم شويه، اعمل كفر اند كفر، خلاص ما بقاش فيه ديفيشن. دكتورة هايدي، انت كنت اتكلمتي على السيرد نيرف فين هايدي، صح؟ لو انا جيت هنا وعملت له سيرد نيرف بولسي توتال، بصي كل حاجه راحت. طب لو عملت كده، لو عملت بورشن حصل توزز وفي. طب لو عملت فول، طيب ايه اللي اتاثر؟ الميديال فوق اللي شغال دلوقتي، الاليفيشن ده حاصل بايه؟ بالانفيريور بليك. والديبريشن ده حصل بالسوبير بليك، انما مفيش لا سوبير ريكتس شغاله ولا انفيريور ريكتس شغاله. هو دي بقى نبقى نقعد في الاسم مع بعض كده، ايه، نشتغل عليها شويه. ده عنده ايه؟ ده انتوا كلكم ماشي. طبعا الشكر موصول للدكتور ايمن على الفرصه دي، ونبقى نكمل بعدين. ثانك يو.
شكرا يا دكتور امجد على البرزنتيشن الممتعه دي، ممتعه فعلا، فيري سيمبل. ويعني عارف اكننا اطفال وبنتلقى العلم من ماما، فهي اتس فيري نايس. شكرا. في اي حد عنده اي اسئله او حاجه؟ دكتوره لبنى.
بسم الله الرحمن الرحيم. First, I'd like to thank all my professors and colleagues for their fruitful presentations, and I hope to benefit from all the next sessions. My talk today is thyroid cases, refer or treat. Thyroid. What is thyroid-associated orbitopathy? Thyroid-associated orbitopathy or thyroid eye disease is an autoimmune inflammatory disorder of the orbit and periorbital tissue. It is the commonest cause of both unilateral or bilateral proptosis in adults. Among patients with thyroid eye disease, approximately 90% have gravis hyperthyroidism, 6% are euthyroid, 3% have Hashimoto thyroiditis or toxic nodular goiter, and 1 have primary hypothyroidism. Case 1. Female patient, 63 years, presented with severe puffy eyelid, double vision on lateral gaze with severe irritation. Past history revealed she was on antithyroid drugs for the past 15 months and stopped since 10/24. Laboratory investigation, TSH was 52, which is increased. Total T4 1.7, normal from 5 to 14. No thyroid scan or trap was done. No sign of optic nerve compression or exposure keratopathy. What should we do? Treat or refer to endocrinologist. Case 2. 50 years old female came complaining of recurrent redness, irritation, photophobia. Her right eye showed exophthalmos from 4 months. Past history of subtotal thyroidectomy. We gave her symptomatic medications and requested thyroid lab profile, which revealed increased antithyroglobulin antibody. What should we do? Treat or refer to endocrinologist. Case 3. Male patient, 31 years, non-smoker but passive smoker, presented with right lid retraction from a mom. Positive history of thyroid disease. Lab investigation was done, revealing normal thyroid profile, but TSH receptor antibody was 1.2. TSH receptor antibody was in the gray zone, antithyroglobulin was normal, and again, what should we do? Refer or treat to endocrinologist. So we need to know some basic knowledge to decide treat or refer. Epidemiology. Thyroid eye disease is the most common disease affecting the orbit. Female to male ratio is 4:1. Severe cases more frequent in more than 50 years age group. Cigarette smoking is the strongest modifiable risk factor. Smokers are 5 times higher risk of developing thyroid-associated orbitopathy. Myasthenia gravis is 50 times more common in patients with thyroid-associated orbitopathy. Pathogenesis. For unknown reason, the immune system produces an antibody, which is the TSH receptor antibody, the TRAP, that stimulates the thyroid gland to produce excess thyroid hormone. Target antigen is shared between the thyroid follicle cells and orbital fibroblast. Orbital fibroblast is the target cell in thyroid-associated orbitopathy. Circulating autoantibodies like thyroid-associated TRAP or thyroid-stimulating immunoglobulins are thought to be the mediators of orbitopathy. Lymphocytic infiltration of the orbital tissue leads to the release of cytokines. These cytokines stimulate the fibroblast. The fibroblast synthesizes glucosaminoglycan, which is hydrophilic, and cause adipogenesis. Glucosaminoglycan accumulate in the fatty connective tissue. It attracts water, causing muscle edema and proptosis, ending in fibrosis of the muscle and atrophy. Clinical picture. 5 main clinical manifestations of thyroid eye disease: soft tissue involvement, lid retraction, proptosis, restrictive myopathy, and optic neuropathy. Soft tissue involvement. Conjunctival hyperemia, a sensitive sign of inflammatory activity, may outline the horizontal recti muscle. Periorbital and lid swelling caused by edema and infiltration behind the orbital septum. Chemosis, tear insufficiency and instability, superior limbic keratoconjunctivitis. Lid retraction. Most common ophthalmic feature of thyroid eye disease. Present in 75% of the patients at the time of diagnosis. Unilateral or bilateral. Due to high level of thyroid hormone, causes sympathetic overstimulation, overactivity of the molar muscle, or fibrotic contraction of the levator and inferior rectus with adhesion to the overlying orbital tissue. We have a lot of signs, for example, the Dalrymple sign, lid retraction in primary gaze, Kocher sign, which is staring or frightened appearance of the eye, and von Graef sign, retarded descent of the upper lid on down gaze. Proptosis. Axial, unilateral or bilateral, symmetrical or asymmetrical. Severe proptosis may compromise lid closure, along with lid retraction and tear dysfunction can lead to exposure keratopathy and ulceration. Restrictive myopathy. Ocular motility is restricted initially by inflammatory edema and later by fibrosis. Most common motility defect is elevation defect due to fibrotic contracture of the inferior rectus. Inferior rectus is the most common involved muscle, followed by medial rectus and superior rectus. Optic neuropathy. Serious complication caused by compression of the optic nerve or its blood supply at the orbital apex by the congested and enlarged recti and swollen orbital tissue. The signs: we have visual acuity usually reduced, color desaturation is a sensitive feature, decreased light brightness, relative afferent pupillary defect, visual field shows central or paracentral scotoma, optic disc may be normal, swollen, or atrophic. The course of the disease. Thyroid-related orbitopathy is a self-limiting disease, being quiescent within 3 to 5 years of its onset. We have the congestive or the acute phase lasts from 6 to 18 months, characterized by active inflammation with marked lid edema, conjunctival chemosis, congestion, and increased exophthalmos. Static phase, in the majority of cases, most of the signs settle down. Fibrotic or inactive phase, eyes are white, however, a painless motility defect may be present. Disease activity and severity scoring. The active inflammatory phase of the disease does not always correlate with the thyroid-associated orbitopathy. Severity, thus activity and severity are assessed separately to guide proper treatment. We have the clinical activity score in active thyroid eye disease is below 3, while active thyroid eye disease is 3 or above. The parameters to assess: first, we have spontaneous retrobulbar pain, pain on attempt up gaze or down gaze, eyelid erythema, eyelid edema, conjunctival hyperemia, conjunctival chemosis, and inflammation of the truncle or plica. And each item is graded by 1, then we add the items. Then we have the European Group of Graves Orbitopathy Severity Association, which is the EGYPTAIR presentation. Mild thyroid eye disease, we have mild lid retraction, mild soft tissue involvement, proptosis less than 3 mm above normal, no or transient diplopia, corneal exposure responsive to lubricants. Moderate to severe thyroid eye disease, we have lid retraction more than 2 mm, moderate or severe soft tissue involvement, proptosis more than 3 above normal, and diplopia. Sight-threatening thyroid eye disease, compressive optic neuropathy, or corneal ulceration. Investigation. Laboratory blood testing, we have TSH, FRET3, FRET4, which is the most important trap, which is the TSH receptor antibody, most specific for Graves. While the thyroid peroxidase and thyroid stimulating immunoglobulin is important in Hashimoto thyroiditis. Visual field to detect optic nerve compression, show central or paracentral scotoma or nerve fiber bundle defect. Imaging, ultrasound. Ocular ultrasound to detect if the patient has thickened muscle or enlarged superior ophthalmic vein. Duplex, comment on the vascularity of the gland. It increases in Graves and decreases in thyroiditis. CT, show thickened muscle with tendon sparing. زي الشكل اللي قدامنا هنا في الاور جلاس باترن بتاع المسل، وهنا في الانلارجد superior ophthalmic vein باين في السي تي. Perform prior to bony decompression because it shows better bony architecture. MRI, more sensitive in showing optic nerve compression. Thyroid eye disease can be classified according to the imaging into type 1 and type 2. Type 1 orbitopathy characterized by predominant fat deposition, while type 2 orbitopathy is characterized by predominant muscle enlargement. Treatment based on the EGYPTAIR classification of the thyroid eye disease severity. Mild cases, stop smoking. Lubrication for superior limbic keratoconjunctivitis and dryness. Topical anti-inflammatory agent as steroid, non-steroidal, and cyclosporin. Head elevation with 3 pills during sleep to reduce periorbital edema. Oral selenium, eyelid tapping during sleep to avoid mild exposure keratopathy, and good adjustment of the thyroid profile by endocrinologist as improper adjustment as converting to hypothyroidism may aggravate the thyroid eye disease. Moderate to severe active disease. Systemic steroid are the first line of treatment. Intravenous steroid administration. Oral prednisolone 60 to 80 mg per day, given initially and then taper the dose. Intraorbital steroid is used in selected cases when systemic steroid is not convenient. Long-acting triamcinolone is used. Periocular methotrexate can also be used with advantage over steroid regarding the IOP reduction. So useful in glaucoma patient and steroid responders. Radiotherapy under steroid cover, immunosuppressive therapy as cyclosporin, azathioprine, and rituximab. Moderate to severe inactive disease. Ophthalmic rehabilitation surgery is considered for patients with stable thyroid levels and inactive disease for 6 months. Surgery is considered in the order of orbital decompression, squint surgery, followed by eyelid surgery, lid retraction surgery, and blepharoplasty. Severe disease, optic neuropathy or exposure keratopathy. Intravenous methylprednisolone in the dose of 0.5 to 1 gram per day for 3 days is often reserved for acute compressive optic neuropathy. Orbital wall decompression is considered if steroids are ineffective or contraindicated. So returning back to our cases, case 1, the patient was referred to the endocrinologist for reassessment and revealed that she took improper dose of antithyroid drugs and stopped without tapering. This converts her to a hypothyroid state that aggravates her thyroid eye disease. The patient was graded 4/7 in clinical activity scoring with moderate severity according to the EGYPTAIR classification. So intravenous steroid was prescribed 0.5 mg for 4 sessions, followed by 0.25 mg for 4 sessions, then oral steroid and immunosuppressive treatment with close monitoring regarding the IOP. She is euthyroid now, moderate inactive, and we will wait 6 months to deal with her residual symptoms, as squint surgery or blepharoplasty. Case 2, the case was referred to endocrinologist for reassessment and was diagnosed Hashimoto thyroiditis, and now on medical treatment to adjust her thyroid profile before reassessing her right exophthalmos. Case 3, the patient was referred to endocrinologist. Thyroid ultrasound was done revealing solitary thyroid nodule. Thyroid scan revealed hyperactive thyroid nodule. Fine needle aspiration revealed follicular lesion of undetermined significance. Follow-up was done after 2 months with conservative measures as stop smoking, selenium daily, lubricant, as clinical activity scoring reveals no activity, and redo investigation according to the recommendation of fine needle aspiration with the same result. But the patient improved with conservative measures and advised follow-up after 3 months. Take-home message: due to the complexity of the condition, the need for careful management of any underlying thyroid dysfunction, the potential threat to vision, and the toxic side effect of many of the therapies, close cooperation between ophthalmologists and endocrinologists is required. Thank you.
شكرا دكتوره لبنى على البرزنتيشن الجميله دي على الثايرويد. وهو طبعا في الاخر وريفير ذا كيس يعني. دكتور اسلام بيه to refer or not to refer is not the only question. اتفضل يا بيه.
صباح الخير عليكم جميعا. في البدايه احب اشكر دكتور مصطفى على تشريفه لينا، دكتور مجدي تشريف حضرتك لينا، ودكتور مصطفى كل سنه يعني حاجه تشرفنا جدا. دكتور امجد شكرا. thank you for your support اكيد يعني. for the all and attendees يعني I'd like to thank you all for referring cases to our unit. Of course I'm kidding. Don't do it again. Anyhow, let us keep it a little bit informal. Okay, let us start. To refer or not to refer, that is not the only question, because of course you know all when to refer a case to the retina unit, and the problem starts with us is what to do, how to do it, and of course solve many problems during doing this. Taking decisions and changing these decisions even during surgery is too much frequently done. Anyhow, ماوس شغال ولا ماوس مش شغال؟ ايه؟ Okay, there is no doubt that knowing exactly when to refer a case of diabetic retinopathy for vitreoretinal surgeon is mandatory, as time is a critical factor to salvage vision in some cases, and sometimes early referral makes our life as a vitreoretinal surgeon easier, and the same for the patient. Now, intravitreal injections are very common, and nearly all ophthalmologists perform, especially in especially the anti-VEGFs, despite the good results, and nearly all types of anti-VEGFs. But also, case selection and good follow-up is mandatory in each case, as some cases may get worse even with injection, either due to wrong diagnosis or from the start, or bad case selection. In the following examples, we will navigate in different cases to see how you will manage. And we are going to focus on diabetic retinopathy, macular holes, and retinal detachment. Okay. First case, it was a 65-year-old female and the mother of one of our colleagues, diabetic for more than 15 years and on insulin, referred to retina unit after being diagnosed as diabetic retinopathy and treated by anti-VEGF multiple injections 6 times in each eye. With persistent macular edema not responding well to injections, patient had a bilateral cortical cataract and fundus examination shows a high risk of peripheral diabetic retinopathy without PRP and a fine epiretinal membrane in both eyes. OCT was done that shows, here we can see the right eye and the left eye with epiretinal membrane, spongy edema in both eyes, and cystoid macular edema in the left eye. Actually, the epiretinal membrane exerting a mild tangential traction over the surface of the retina. At this point, my decision was, as a patient actually is not controlling her diabetic conditions very well, my decision was to do vitrectomy, actually. As both eyes has the same problem, we will focus on the left eye, as it was affected more and had a worse best-corrected visual acuity, which was 624. My opinion at this moment was to go for phaco-vitrectomy and endolaser, as injections may increase the traction formed by epiretinal membrane, and PRP might be difficult or even incomplete due to poor dilatation and cortical cataract. But patients sought another opinion with two of our professors, and both advised PRP and injections. I don't know, Dr. Mustafa, what would you do in such case?
هي الحاله دي التركه فيها ان هي عندها كاتراكت، فانت مش قادر تعمل
Yes.
بي ار بي كويس، مش عارف تعمل ايفالويشن كويس.
Yes.
لكن لو احنا الانديكيشنز فور فيتريكتومي جاست عشان الممبرين
No.
ده لا، ما
No.
هيش انديكيتد.
But I couldn't do a full PRP in such a case.
بالظبط.
And I have to do cataract in both eyes to do PRP despite the poor dilatation. And again, when I took the decision for cataract, I asked the patient to go for phaco-vitrectomy from the start, and she also refused.
طب يعني انت عندك تو اوبشنز في الحاله دي. الفيرست اوبشنز ممكن تعمل كاتراكت ويز انترافيتال انجكشن اوف كورتيكوسترويد اوزوردكس مثلا.
Yes,
ليه؟
that's
لان
what we
الحاله
had
دي
done.
فيها ساينز اوف كرونيستي واضحه جدا.
Yes.
فالساينز اوف كرونيستي دي اجينست انك تنجكت انترافيتال انتي فيجف، خلاص
Yes.
هاز نو رول. فهتعمل كاتراك انجكشن وتحقن اوزوردكس فور اكزامبل يعني كورتيكوسترويد، وتعرف البيشنت ان احنا وي ار جوينج تو اكزامين ات مور اند مور اند if we need to do PRP later on we can do it.
Yeah.
Or
sooner
the
or
second
later-
options phaco-vitrectomy as we
I told her
said.
that we are going to need vitrectomy sooner or later, so it is better to be sooner, so as to at least اوفر عليها بس انها داخله خارجه المستشفى اكتر من مره. So against my advice, we started injections and laser, which of course was impossible. So patient was advised to do phaco in both eyes, and again I tried to convince her for phaco-vitrectomy, but in vain. Then did PRP in both eyes after phaco and continued to inject, but at that moment I decided to inject Ozurdex, which was effective but temporary, and here is the OCT for hair progression. Of course, the first OCT was done in 2021, and in 2022, here are the signs of traction. VMT starts to appear, and in 2023, actually, it was much more obvious. There is no cursor, but I think you get the message here. Okay, at that moment, and with drop of vision to less than 636, as the vitreomacular traction was progressing, I told the patient there is no other alternative than to go for surgery. So vitrectomy was done with endolaser and silicone aisle tamponade, of course, because there was no available gas. Followed 2 months later by silicone removal and improvement of visual acuity to 612. Here is a OCT immediately following surgery and another OCT after removal of silicone. As we can see, the condition become more stable. So the overall problem in vitrectomy in proliferative diabetic retinopathy is bleeding, which is decreased by anti-VEGF injection 48 hours before surgery to find the, and the other problem is to find the plane for dissection and to remove fibrovascular proliferation effectively without damaging the retina as much as we can. This could be very challenging in many cases, especially if long time fractional retinal detachment was present with viscous subretinal fluid that might take months to resolve after removal of traction. Splitting of posterior vitreous face in 2 or 3 layers may make it mandatory to use triamcinolone to identify all posterior vitreous layers before finishing the surgery. And as example, it is a case of proliferative diabetic retinopathy, and after removing much of the vitreous hemorrhage, we can see that the attached posterior vitreous face is very evident. There was minimal fibrosis surrounding the disc, but actually this is the most difficult type of fibrosis that should be removed. As we can see, the vitreous is very attached, and the signs of PRP is very evident. And this actually, we all noted that PRP prior to surgery and old PRP leads to very attached posterior vitreous face and the splitting actually of the posterior vitreous face. As we can see here, removing of fibrous tissue that might be very challenging after reaching a plan for dissection. Here is the splitting and removal by staining. Actually, I do not prefer to early staining of triamcinolone in surgery in peripheral diabetic retinopathy. Actually, just to identify the plane and see the epicenters. But eventually, after removing or induction of PVD or reaching a plan, I might use triamcinolone to stain the multiple layers of splitted posterior vitreous face. Now we have moved to bimanual here to remove the fibrous tissue, as you can see, using a chandelier and scissors and forceps, actually the crocodile forceps is rated, I mean. And very carefully removing this fibrous tissue. And without causing any breaks as much as we can. Of course, it is challenging in many cases, but as we can see, it can be done. Here is another case. Also, proliferative diabetic retinopathy. I'm sorry for the video, it was not that good actually in quality. But here we didn't use bimanual dissection. Actually, we used the 23G probe, just the probe, and finding a plane and following every single epicenter by circumcising around, then removing the fibrous tissue, and so on. Of course, bleeding can be very challenging during this surgery, even when we are doing a prior injection of anti-VEGF. During the surgery, if there is bleeding, you will be surprised that blood is going to be a very tough tissue within few minutes, so you have to remove as soon as you can. Here is a posterior vitreous face removed and taking out the excess blood as much as we can. Sometimes the bleeders are very evident. When you are doing just suction, it will not stop, and gentle pressure over and elevating the pressure of the bottle may help. And sometimes it is very difficult also to remove this blood. Now, continue. Like you can see, the blood became a tissue that needs a cutter to be removed. It cannot be just removed by suction. Fibrous tissue, epicenters. Again, very carefully with the probe only. And of course, the bleeding can be solved by gentle pressure. Now moving to this part of fibrous tissue that needs to be removed using the cutter also, not by manual, just the cutter, finding the plane, finding the epicenters, but sometimes the cutter is not enough and you have to use scissors. The mouse is not working. Can I fast forward some videos or not? Could you please fast forward a little bit? Now using the scissors to cut the epicenters. you can see, then using the cutter again. Blood becomes a very tough tissue, but finally it is removed. And of course, if you are not going to do any tamponading, if there is no retinal breaks, so air will be enough. And in this case, I prefer to do ILM peeling as there was tractional marks over the macula. So we have to do ILM peeling. I don't think we have to do fast forward right now because actually the video has finished. I'd like you to have a look on the final picture. Now, this is before fluid air, as you can see, and air is enough as a tamponade in such a case. Now we are going to move for macular holes, and this is the algorithm that was presented by Dr. Tamer Mahmoud for macular holes. And my preferred technique actually with multiple inverted ILM flaps. Sometimes I use the temporal flap, but I found it a little bit difficult to do in many cases. Anyhow, this is the types of closure of macular holes following surgeries. But let us have a look, and this is a video for multiple inverted flaps. Let us fast forward a little bit. Sometimes I use perfluorocarbon just to be sure that the multiple flaps are over the macular hole, especially if it is a little bit large. And of course, fluid air and just air is enough in those cases. Now, this is a case of temporal flap that we have tried. As you can see that the macular hole is not that large, actually, and the patient is not very old. Actually, he was about 63 or so. So we have to do temporal flap, but unfortunately we have bleeding like this, and as you can see, as I told you before, blood can be a problem. It becomes a tissue in no time, so we have to stop for a while and remove this blood. And sometimes it is a little bit difficult to stop. Gentle pressure is not always enough, and take care here while you're removing. You might lose the flap, but thank God that it didn't happen in this surgery. As you can see, the blood become a very tough tissue attached to the retina. And sometimes it is a little bit difficult. And when removing this clot, you will find it bleeding again. And you have to exert gentle pressure and actually elevating the intraocular pressure that was not helping in this case. And I have to use also perfluoropupil just to do compression and continue the temporal flap. I don't know why I continued to do the temporal flap, but it was very tempting to do, and the ILM was very clear. So I continue to do a temporal flap in such case. And of course, after fashioning the flap very well, we have to enlarge the ILM. But unfortunately, this case, after absorption of air, I found that there is no flap. There is no ILM flap, and actually the macular hole become larger. So actually I regret on doing temporal flap in such a case. And I have to go again and do multiple flaps, multiple inverted ILM flaps. and using a little bit long-lasting gas, in such case, not air, of course. As you can see, the flap was a little bit torn, and the rest of the flap just go back to its original site, and I have to remove it again. Fashioning multiple flaps. And fluid air, drying of the flaps very well using a soft tip fluid needle. And this is the end result after absorption of long-lasting gas. Sometimes you face another problem, a macular hole following vitrectomy actually, and this was a patient with 69 years old with diabetic retinopathy and fibrovascular proliferation and vitreous hemorrhage, to which we did phaco-vitrectomy and endolaser with removal of epiretinal membrane and peeling of ILM. After 2 months, we found this. She has a macular hole with localized detachment of the macula, and of course, we have removed the ILM before, so we have to do autologous retinal transplant, and we have presented this case last year. And this was a OCT after doing autologous retinal transplant 1 week and 1 month and maybe 3 or 4 months later. As you can see, the patient improved. For retinal detachment patients are usually the most appreciating patients among all retina patients, but simple recent rhegmatogenous retinal detachment is not always the case. Next case of dropped IOL during cataract surgery. Unfortunately, the anterior segment surgeon tried to retrieve the IOL and apparently was exerted too much effort in his trials but failed, and after 1 week patient was referred to our unit with lower retinal detachment and radial large retinal break and actually a scratch in RPE. Here we can see the radial break of the retina with starting PVR, and of course the IOL has to be removed after doing core vitrectomy and removing the posterior vitreous, relieving the IOL from all attachment of the vitreous, then delivering it, go back to surgery, remove the rolled edges of the retinal break, excising it after, of course, endodiathermy, doing very meticulous vitreous shaving. As we can see, there was remnants of bleeding due to the first surgery trauma, doing meticulous also shaving and searching for secondary breaks. As we have seen, there was a small peripheral break. Then using perfluorocarbon again, and fluid air, of course, and silicone oil in such case, and actually it went well after that. Okay, the second case was a young male patient suffering from renal failure and on dialysis, referred to our unit with vitreous hemorrhage and retinal detachment proved by P-scan ultrasonography, and he was trying any trauma, of course, on anticoagulants, and he is a high myope with axial length of more than 30 millimeters nearly. And this was a picture during surgery. After removing the anterior vitreous face, we found that the retina has a total retinal detachment, which was hemorrhagic retinal detachment. There was no breaks whatsoever, but there was subretinal fibrosis, as you can see, nasal and temporal, at the nasal and temporal quadrants. Of course, with such a thing, and the retina is becoming shorter and hemorrhage below, we have to do retinotomy, and I choose the site for retinotomy on the temporal side and the nasal side near the areas of fibrosis, so as to remove any fibrous tissue and became in a more dependent area, and actually has a maximum effect of silicone later on. Of course, here we have to use triamcinolone to be sure that we have removed all the vitreous. Using perfluoro, as you can see, blood is there, doing retinotomy. As the retina configuration shows, there was no breaks whatsoever. All the detachment was caused by hemorrhage. And you can see the viscous subretinal fluid coming out just from the retinotomy, then blood, enlarging the retinotomy temporally and nasally, flipping the retina and trying to remove all the hemorrhage from below. Actually, it was a very difficult and long case. And they are asking why you all have heart attacks early. Anyhow, fibrous removed. Then, of course, laser. And you can see while doing fluid air, the retinotomy become much more larger as the retina was really short. So actually, this case went well for retinal detachment, but I think if I go back by time, I would have done 360 retinotomy, not only 2 quadrants, temporal and nasal, but actually I was very afraid in doing this case, as I don't have a clear preoperative diagnosis. I didn't know, and I didn't actually expect that it will be a hemorrhagic retinal detachment. The third retinal detachment case was a young phakic female patient with previous vitrectomy for retinal detachment and silicone-filled eye. That lost follow-up and came back with mature cataract and recurrent retinal detachment under silicone. We decided cataract surgery with silicone eye removal and recurrent retinal detachment surgery. And of course, in these cases, we will be very careful in doing the capsulotomy and doing suction. But of course, this does not prevent Argentina flag sign. I'm going to let you enjoy this case as I enjoyed it very much. Using dinitra is mandatory. Moving excess flaps from the capsule and continuing the phaco. Actually, in these cases, the phaco, the lens is very soft, actually, even if it is mature. But of course, I was trying not to injure the posterior capsule as much as I can, as I know that the patient is silicone filled, and I'm going to use silicone again. Mouse is not working, actually. Sorry, I was trying to fast forward, but in vain. Now, after removing the cataract, removing the silicone, sorry for this, but the mouse is not working. I would have escaped. Anyhow, and go back again with, as you can see, there was epiretinal fibrosis surrounding the original break and subretinal fibrosis, and this band actually extending up to the macula. So we have to do retinotomy and removing this subretinal band, or at least cutting it. Then releasing the rest of fibrosis around the original break. Then doing fluid air, laser surrounding, and of course silicone again. As you can see, part of the band was removed, not all of the band actually, and removing the fibrous tissue around the original break, using perfluoro again and the fluid air and silicone, and actually the case went well. So to summarize our life, let us imagine like if the challenges in the eye are talking to us in the next video. Please. شغلوا شغلوا بعد اذنك يعني تعبنا فيه يعني. شغلوا هو اللي بيغني، انا هعمل لك ايه طيب؟ اخر سلايد بقى لو سمحت. اخر فيديو. طه وهي بتغني يا راجل، هي ناقصه مشاكل يا عم، في ايه؟ انت مصر؟ تايم يا فندم، في 3 دقايق ونص. ها شغال؟ يلا صوت بقى من فضلك. يا دي الحوسه. ايه؟ اغني انا؟ مفيش صوت اعلى من كده شويه؟ حط لك المايك جنب انا عملت اللي عليا الصراحه. هو من غير خايف من خياله، هو خايف من خياله الصراحه. خلاص This was a sub-eye limb bleeding case. سيبه مرة يجرب temporal flap وبعدين تفيل عشان يتعلم الأدب. يلاقي نفسه داخل تاني فيتعلم الأدب على طول. بعد كده multiple inverted. آخر جزء من الأغنية طبعا فيديو ما اتعرضش قبل كده. This was a metallic foreign body removal and Yemeni technique for IOL implantation. Actually, we didn't find the foreign body. We know there was a foreign body, but CT does not appear, and P-scan actually. And during vitrectomy, I found it just stuck to the back of the iris. Of course, يعني يتعب شوية 3 hour surgery. Then it drops down over the retina. تحكوا. It's our life. It is not an hour of our life. Using the remnants of the capsule as a shelf to remove the foreign body. It was a case of ruptured globe with metallic intraocular foreign body. Actually, we have presented this case once in EGYPTAIR. Thank you.
شكرا يا اسلام على البرزنتيشن والشغل الجميل ده، يعني ما شاء الله. وشيرين طبعا عملت الواجب. ثانك يو فيري ماتش. في اي حد عنده اسئله على الثلاث سيشنز؟
وانت تسلم ايديك يعني، والله يعني
يخليك.
شغل كويس جدا جدا، وقلبت على المواجع بالفيديو الاخير دوت. انا حياتنا سامرايزد يعني. But let me to share with you some of my little experience في بعض النقاط في بعض الحالات. هحاول اختصر لان الفيديوهات ما شاء الله كتير، فاريشنز كتير، كلها حالات صعبه جدا جدا. هنبدا بحاله الماكتر هول والتمبرال فلاب اللي حصل فيها ريكارنس ودخلنا مره ثانيه. الحقيقه عشان التمبرال فلاب يعني انا شفت من الاكسبيرينس من خلال الشغل، علشان الهول يقفل لابد انك تعمل البيلينج اتليست 180 ديجري. يعني لو لاحظت حضرتك لما جيت تعمل البيلينج مره ثانيه في السكند تايم او السكند انترفنشن، كان ستيل الاي ال ام لسه انتك كل الجزء.
لا ده هو رجع
والنيزل.
ما هو الفيديو اللي قبليه كان بيقول لحضرتك ان انا وصلته لغايه التمبرال فلاب 180 ووسعت اول اراوند،
ورجع مره ثانيه.
هو لما رجع فرد ومسك.
ما هو عشان حاجتين لازم تتاكد ان هو ريليزد خالص كل تراكشن، وتحاول تعمل له انفرشن. يعني بعد ما تلفه حاول تعمل له انفرشن في قلب الهول. الفكره كلها انك تليف كل التراكشنال فورسز وتسيب بس الجزء عن البابيلو ماكل باندل. لان احنا في بيبرز كنا لسه عاملينها قريب قوي، لقينا لما بنعمل كومبليت بيلينج بيحصل شورتنج في الديستانس ما بين الديسك والماكل. يعني كسكند او سكندري او سايد افكت بقى من الايلاند بيلينج بيحصل شورتج فبيبيلو ماكل باندل. فلما انت بتسيب الجزء ده اتاتش ستيل زي ما هو، بتقلاو ان ازاي التمبرال بارت كلها هي اللي تبدا تدي ريليف التراكشن، فتدي فرصه للهول ان هو يقفل.
ده معنى كده بقى ان الريتراكتنج دور اي ال ام بيلينج is going to be obsolete.
لا الكومبليت بيلينج اوف اي ال ام بيعمل شورتج في البابيلو ماكل باندل، ودي يعني
temporal او retracting
التمبرال بيحافظ عليها. الحاجه الثانيه بسرعه، حضرتك يعني تعبت جدا في الحالات دي اللي حصل، مش دي حصل فيها بليدنج مش كده؟ يعني يو شود تو هاف دايما. انا عارف ان ما كانش معاك اكيد سوفت تيب فلوت نيدل.
لا موجود بس مش يعني مش كل الحالات بتقدر تلحق. انا على ما تطلع وتخرج لقيت البلاد خلاص بقى تيشو.
لما تيجي تشيل بقى حضرتك شلت البلاد بالبروب
بالبروب لانه كان الفاكيوم
بقى جامد وبيعمل تراكشن، فحصل لك بليدنج تاني بقى.
ريبليدنج.
سبست بقى السوفت تيب فلوت نيدل تعمل بس زي اكنها تعمل سويبنج وتسيب الكلوت بلاد على الحته السنترال.
هي بقى الحته ديت البلاج ده عشان ما يقرفناش بعد كده،
عشان ما يحصلش بليدنج تاني. الحاله الثانيه جميله قوي بتاعت الدروب دايويل اللي كان فيها بريك، واضح ان البريك ده من الايويل.
هي it was an acrylic IOL بس I think ان ديت was by the trial.
هو المانيبيوليشن اللي عمله الجراح بتاع الانتيريور سيجمنت، وهنا بقى وين تو ريفير. هو عندي سؤال تاني بقى، ان بعد البريك ده كان في بريك تاني صغير فوق.
both were treated.
عملت انت حضرتك شيفنج عليه؟
yes
وسيليكون. الحاله دي حضرتك شفتها في الفولو اب؟
yes.
طب ما حصلش ريكارنس الحمد لله؟
لا هو حصل retinal membrane. I didn't do ILM peeling in this case, but later on it has an retinal membrane that we have removed during silicone removal.
طيب هو في الحالات دي عشان نقلل الانسف ريكارنس على قد ما تقدر وصل البريكس باللي فوق، يعني انا فاكر المسافه بينهم صغيره قوي.
لا بس هو one was temporal and one was inferior.
لا كان في البريك نفسه الكبير ده اللي فوق منه ده كان بريك ولا كان مجرد
لا this was just shaving.
ما كانش فيه بريكس فوق.
ما
كنتش شايف كويس. طيب اخر حاجه الحاله اللي كان فيها توتال ار دي وبلاد وقصه كبيره، دي حاله وحشه قوي قوي قوي. حضرتك هي التركايه بس هنا، انت حضرتك البي اف سي حطيته والبابلز والريتنا كانت فوق عشان تفردها،
علشان انا we couldn't detect the break.
صح كده؟
we have surgery.
طيب I prefer for my experience في الحالات دي اعمل انت في الاول خالص ياتروجينيك بريك فوق،
ما هو انا ما كنتش عارف
البريفري.
لسه هختاره فين. انا كنت شايف السبريتنال فايبروزس
خليه
تمبرال ونيزل.
في اسهل حته توصل ايدك ليها، وافتح وفضي الفلويد الاول عشان الريتنا ايه
ما هي
تهدى
عشان تنزل
والبوستير بول يبان. ليه بقى حضرتك؟ وار فيري لاكي ان ما كانش فيه هول،
ما كانش فيه
ماكولار هول، ما
اه
كانش فيه بوستير بريك.
لا هو بس البلاد اللي كان اللي انا ما كنتش عارف اذا كان ليكويفايد ولا في منه كواجيليتد، عشان كده ما
هيطلع
قدرتش.
ما هو طلع لما حضرتك عملت ريتنكتومي.
ده عايز اقول لحضرتك it was a 3-hour surgery يعني
طبعا
في جزء
طويل
كبير
قوي.
منه كان coagulated. I have to flip the retina and pull it.
هي بس ماي مسج ان ما نحقنش البي اف سي وانا مش شايف البوستير بول، لان لو في بريك او هول هيدخل سب ريتنال والحاله
ده
هتبقى
أكيد.
ديزاستر يعني مش عارف فيها
طبعا.
حاجه. فالبريكس البريفري ديت انت الله يكون في عونك حاله يعني ما اعرفش تجيب الحالات دي منين.
مش عارف والله بس انا قلت لهم يعني بليز دو نوت ريفير
اخر تعليق ليا واتمنى ما نكونش الناس بس اتضايقت مني. حضرتك في اول سلايد قلت ان الانترافيترا انجكشن بيتعمل بكل الدكاتره يعني قول بجد.
يس
لا يعني بس انا بصراحه انا شايف ان دي حاجه يو ماست ريفير ذا بيشنت. احنا شفنا حالات كتير جدا داخله تعمل انترافيترا انجكشن وتجي لك بار دي. وليه انت المفروض قبل ما تاخد الديسيجن بتاع الانترافيترا انجكشن هتعمل جود ايفالويشن للبريفري اوف ذا ريتنا كويس جدا. لو في اي تراكشنال فورسز موجوده في البريفري، لو في اي ابريتال برين موجود في البريفري وانت حقن، يا اما انت هتعمل ميكانيكال وانت داخل تشد الفيترس وتعمل ياتروجينيك بريكس، يا اما الكونتراكشن اللي بيحصل من الممبرين دي هيعمل لك هو ياتروجينيك بريكس، وبعدين يجي لك بعد كده بار دي. اسخف انواع الار دي اللي تقابلك الكومبايند تراكشنال ريجماتوجنس ار دي في عيان دايابيتك. اسوأ عيان ممكن تشتغله عيان ار دي لما يجي لك ديتاتشمنت نتيجه بريكس ريجماتوجينس وهو اصلا دايابيتك وعنده بي دي ار. فانا معترض على حته ان الانترافيتيال ده يتعمل باي دكتور. لا يعني ريفير، ما احنا بنريفير يا جماعه حالات القرنيه وحالات السكول ما من حاجه فيها. طب يتحنوا الانجكشن
والله كفايه يعني كفايه.
وانا هريفير الليزك ليه؟ لا وحالات والله في حالات ليزك كومبليكيت ما بعملهاش، ببعتها والله ببعتها بتاع ليزك وانا مش شغل. حاله فيها ثيننج في الكورنيا حاجه بتاع
برضه حاجه
طبعا. وشكرا ليكم والله كان سيشن ممتع ومتشكر جدا دكتور اسلام الحقيقه.